everybody. I'm Jeannie Blaylock here at First Coast News, and we want to make you smarter about something called Lp(a). If you're going, I don't even know what that is, that's okay. I didn't know what that was either, but I have found out it's a mean type of cholesterol. The deal is that some 60 million Americans have a high level of Lp(a), and they don't even know it, and it can possibly make your risk of a heart attack double or triple. So the good news is we have two experts to help us through this, how to figure out if you have it and what you do about it. There they are right there. We're going to introduce them in just a second. But before we do, I want to say that coming up, you're going to see on the bottom of your screen here, this week in Jacksonville, next week, Monday, Tuesday, and Wednesday, there is free testing for Lp(a). We're going to tell you why you should do that, how you do it, and what it means to you. So let's introduce our experts. We are glad they're here tonight from Baptist. We have Bonnie Appler there in the pretty blue dress tonight. She is a certified lipid specialist, and also from Baptist, we have cardiologist Dr. Raymond Mai. So we appreciate you all being here. You're experts on Lp(a), and so Dr. Mai, let me first ask you, what is it? I know it's a bad cousin of the bad cholesterol.
That's correct. Thanks for having us today. So Lp(a) is lipoprotein A. It's better known as Lp(a), and this is a genetically inherited risk factor. So patients, about 1 in 5 patients generally have this mutation, and it produces a protein that attaches to the normal LDL, and it makes it really aggressive. So
yeah, and so while you're talking, can we show some video of some cholesterol? We've got kind of like a diagram inside the artery so you can kind of explain what we're talking about.
Sure.
So what do we see in there? This is an animation.
Yeah, so this is just red blood cells with some cholesterol. This is a more scientific diagram of Lp(a). So you'll see lipoprotein A attached to a normal LDL. This is what makes it unique. The lipoprotein is a molecule that is genetically different. So the LPA gene is what causes the production of this, and the variation in how much is produced, it differs from patient to patient.
And so we want to tell people, Bonnie, is that I've never heard of it either, as I said, but you have identified hundreds of patients at Baptist that you're working with right now who have high levels of this. What can it do to you? Why can it be bad?
It acts like an LDL molecule, but super sticky. It gets into the arteries and kind of gums it up even harder, even worse than a regular LDL molecule.
And so it's not just heart attack we're talking about, possibly, right?
Right. Heart attack, stroke, vascular disease, all throughout the body.
And so let's get personal for just a moment. Bonnie's told me this wonderful story. You have a very passionate reason for talking about this, and that is your dad, who happens to be a cardiologist, Dr. Smith. Tell us that story.
So my dad is a cardiologist. I was raised in a cardiology household. I've been in cardiology for 18 years now, and my brother is also a cardiologist. Several years ago, actually around about 10 years ago, my dad called and said, I've been having some chest pain. And there we are. He said he had been having chest pain and asked if I would drive him to the hospital. I was actually working for him as his PA at the time. And I drove him into the hospital. He was having a heart attack. He had 5 blockages, one chronically totally occluded artery. He got a couple of stents and a balloon. And his life was saved that night. But in the next couple of years, we kind of discovered that he had this lipoprotein A. We thought, this is so strange. Why, if as a cardiologist, you've been altering everything you can, like blood pressure was perfect, cholesterol is perfect, diet, he hadn't had red meat in 7 or 8 years, but he ended up having a heart attack. And so it's genetics, age, and gender, and the genetics is actually what ended up getting him, and it was Lp(a). I've had mine tested. Mine is elevated. My brother's is elevated. So we're doing everything we can at this point to mitigate our risks.
And so if he had known, if that testing had been available, would that have made things less traumatic for your family if you had known he'd had a high level of LP little a back then?
Potentially could have altered the course of things. Treatment now is, more treatment is available. We have more options for lowering LDL lower, getting it as low as possible, and a few that help lower lipoprotein A. If we could have had him on something like that, absolutely, probably could have changed his outcome.
And Bonnie's just touched on something we're going to talk about in just a little while, and that is there are some drugs in the pipeline that may come out in 2025 or 2026 for the first time in the United States that can give us some hope about treating LP little a. So we'll get to that in just a second. But Dr. Mai, I want to ask you, how come we haven't heard more about this like years ago? I mean, doctors knew about it, right? Why is it just breaking into the public consciousness?
Yeah, it's generally thought of as a silent risk factor. It's not picked up on a normal cholesterol test, and it has to be intentionally tested. And that's where we run into some issues. It tends to be availability of testing, education of the provider, and things to look for. There are certain characteristics of patients that make you think of LP little a. For example, patients who have disease early in life, in their 40s and 50s, multiple generations of family members with heart disease, and patients who get recurrent disease despite doing the right things, changing their lifestyle, quitting smoking, and drinking in moderation, and exercising, and yet they still get recurrent disease. These are patients that we tend to look for in testing because there is always a risk factor that may not be picked up. If we're getting disease despite doing everything that is visible or tangible, then there has to be something else. And that's when we generally look for LP little a.
And so you only have to get tested once in your life for LP little a. Why is that?
Correct. So LP little a, the level of LP little a generally stabilizes by the age of 5. The levels go up and down based on inflammatory factors. So inflammation can tend to cause it to go up slightly, but the levels themselves generally stabilize by the age of 5.
So let's talk about who should get tested.
Yeah, so, if there are family members who have been tested positive for LP little a, those are the first people we generally test. Patients who are discovered to have disease early in life, men under the age of 45, women under the age of 55, we generally test those. And once we find that they're positive for LP little a, we generally test their family members as well. There is a class of patients that sometimes get overlooked. For example, patients who continually have severe disease despite maximum therapy in their cholesterol therapy, lifestyle changes. And there's one last class of patients that sometimes we overlook. These are the patients who you treat with maximum therapy, and yet their LDL, which you can test on a normal cholesterol test, barely responds. Those are the patients that you should end up testing.
And as you've been talking, we've been looking at some video. That's Miss Thomas's family right there. I've met them. They're in Jacksonville. They got tested because they realized they had heart disease in their family, so they wanted to make sure they got tested. And if you're wondering, well, what does that mean, get tested? It's a simple blood test. And after she had it, she goes, oh, I didn't even feel that. That didn't even hurt, because I don't like needles and blood tests either, but it was really not that big of a deal. And so, Bonnie, who would you encourage to come to this free testing? You see at the bottom of your screen. And this, by the way, this location is near the Potter's House. A lot of people know where the Potter's House is. So they encourage you to make an appointment. You see right there, it says to book an appointment. You can go to a certain website, or you could just walk up. But Bonnie, who should go and get tested?
I think anybody that's interested in knowing their risk. I think, since cardiovascular disease is the #1 killer of humans, I think everyone should know what their risk is. If you know, then you can make a change. You can see trouble ahead and change your path.
Well, let's talk about the risk for African Americans and Southeast Asians. It's different, right? Isn't it, Dr. Mai? Dr. Mai, I'm sorry.
Yes, that's correct. So this gene tends to present a little bit higher in African Americans and in Southeast Asians. Although we do see it in some Europeans as well, we tend to find this more commonly in African Americans and, like you said, in Southeast Asians. So
should your children get tested? How young can that be?
As young as 5 years old. They'll generally produce a level that can be measured, and that level tends to be stabilized by then.
Well, Bonnie, if you find out that you have a teenager with high levels of LP-Little-A, what are you going to do about it?
Take them to a cardiologist.
Yeah.
Take them to see Dr. Mai.
There you go. And what do you say, Dr. Mai, for younger people? I think this testing, they're asking for people ages 18 and up, but are you saying that you could go to a doctor and have a child tested? Is that a good idea?
Yeah, so our European colleagues have already, recommended that everyone at least once in their lifetime get tested. We haven't really made that recommendation here in America yet, and there's no concrete recommendations. However, certain things make us tend to, choose to test more often. But yes, I think, at least once in everyone's lifetime, they should get checked.
And so let's talk about the drugs down the pipeline. And we know that Amgen, Eli Lilly, and Novartis, all three of those companies are in some sort of phase of clinical trials, not yet totally FDA approved for the market, but possibly we might see something on the market for the first time in the U.S. in 2026, perhaps. Never know how that's going to go. But I know you can't endorse, and you will not endorse any particular drug. But what can these drugs do? How do they work, and do they really give us some hope here to combat LP-Little-A?
Yeah, it's interesting. They're trying to target it in two ways. There are drugs that try to silence the gene, and then there are also drugs that try to prevent the attachment of lipoprotein A to the LDL molecule. In theory, it should work. I think to be determined, I guess.
And so there have been some studies, preliminary studies in JAMA, correct? In the Journal of the American Medical
Correct.
Society. And then what about when you guys go to your cardiology meetings nationwide? What kind of talk is there about these drugs?
There's some talk that they could be reducing LP-Little-A up to 90%.
And so how does that work? Are we talking about just getting rid of it out of the arteries so it's not sticking to the artery walls?
So that's interesting. So atherosclerosis is a lifelong disease. Once it starts, it tends to be a lifelong disease, and that's why testing early is important. And living a healthier lifestyle is important. So once you target LP-Little-A, you tend to stabilize the disease where it's at.
Let me ask you one question. I had heard, Dr. Mai, that you are super passionate about this topic. Let me just kind of go to that overall question, which is, why are you so passionate? I mean, are you frustrated that people don't really know very much about this? Why are you passionate about it?
Well, heart disease remains the number one killer. Kills twice as many people as cancer, and yet we pour billions of dollars into research, and so heart disease tends to get overlooked a lot. It's unclear why, but it tends to get overlooked, especially smaller topics like LP-Little-A, things that we can't physically see or not commonly tested. These things tend to get overlooked quite often. But heart disease, we can prevent heart attacks, and I think that's the big takeaway from this.
And Bonnie, I think you have some patients who've had stents or some sort of heart procedure, and you said, if I'm understanding correctly, that they failed sooner than you thought they would, and that might be related to LP-Little-A. Straighten me out, is that right?
Yeah, no, that's right. I've had a good handful of patients who have gone for bypass, had their arteries rerouted, and they end up with redo bypass. A lot of these patients close their grafts within a couple of months of having surgery, and it's unsettling. Even if their LDL, or the main marker that we're kind of gauging things by, if their LDL seems to be in a normal range or in a protective range for someone who's had bypass or had stents, they still are at risk. So, and they come back and they say, I don't understand. We've been treating my cholesterol. I'm on 2 medicines or sometimes 3 medicines for cholesterol management, and I'm still having events. So those are the people too that really pique our interest, and it makes us immediately think, oh, you probably have this genetic marker. If you have this genetic marker, we're going to do everything we can to reduce your risk with it.
And so, Dr. Mai, you see patients all the time. What do you want to add to what she just said?
Yeah, so sometimes, when there's a discrepancy between your cholesterol and what's happening clinically, we tend to look for LP-Little-A. It is a risk factor, like I said, tends to be a silent risk factor. And It's not as well understood yet, but as we learn more and have drugs to treat it, I think the future will be brighter.
So I want to go back just a bit in case someone's just joining us now. Bonnie, let's call up that cholesterol video, our producers here, and let you explain about the tail, why it's sticky, what it does inside your arteries. There's that tail. It's got another name too, doesn't it?
So, well, the LDL, Lp(a) is like an LDL molecule that has that tail on it, and that tail is what makes it stick. You can see in this video the yellow stuff, that yellow plaque along the inner wall of the artery. That is plaque. It could be some Lp(a) in there, but the tail is what makes it specifically more sticky, makes it gluier and stick more to the walls of the arteries.
And I think your dad described it as like a bad cousin or
Yeah.
a mean stepbrother or something to LDL, like
Yeah.
an LDL on steroids. Is what I've heard people
yes.
say. And that sounds pretty bad. So, Dr. Mai, I just am wondering now, though, there are a lot of people who do want to take care of their health. I interviewed another family the other day, and I'm still working on that story, but he said, I just want to be healthy. I always want to know information. Please educate me on this. So people are hungry for this information, and a lot of people, as we say, haven't heard of it. But Dr. Mai, what if somebody right now is thinking, yeah, but if these drugs aren't out yet, why should I, in March or whatever of 2025, find out if I have a high level of Lp(a)? Because this may be a year out before we get these drugs.
Of course. So we still have hope. Just by lowering our overall risk, we can tend to reduce risk overall. Lp(a) tends to still be an independent risk factor. However, once you know that you have Lp(a), you'll make healthier choices generally, and that helps you reduce your overall risk. That tends to help reduce risk somewhat while we're waiting for some of these drugs. We do have some drugs out there, certain classes of drugs that can reduce Lp(a) by up to 20 to 30% in some of our studies.
And what kind of classes of drugs are those?
So these are the PCSK9 inhibitors. These are shots that you'll get either monthly or twice monthly.
PCSK9 inhibitors.
Correct.
So if Dr. Mai is not your cardiologist, you can ask your doctor about it, right? Okay, and I know when I go get cholesterol, I get the HDL, I get the LDL, but should I ask if I don't make it to this testing event? Should I say, hey, can you please include it on the panel? How does that even work? Does your insurance cover it?
Insurance does a pretty fair job of covering it. I have found that for the most part, maximum $25 more than a regular lipid panel is this expanded cholesterol profile. A couple of the different labs have a lab set called a cardio IQ. You can have that drawn. You could have the individual particles drawn as well. I know at Baptist, we draw people's cardio IQ all the time. They send it off, and 2 weeks later, we have the result with all of the breakdown of the different lipid particles.
And so let me just kind of get nitty gritty. Like I said, I've interviewed that family, and then at this other family I just talked to the other day, they already have cut out, there's a husband and wife there, and she's already cut out fried chicken. He doesn't want to cut out fried chicken. But when they're going to get tested next week. But if they do have those Lp(a) levels that are too high, and you've already started the salad diet and exercise like the wife has, what are you going to do about it just in your own home?
Yeah, so that's interesting. Even if you go into a vegan diet, Lp(a) the levels are still there. You can still test for it. Obviously, by reducing overall risk, you can reduce your risk, but this molecule still tends to be present in your blood. Like I said, there are some drugs out there that can help us with this, and knowing is the first step. I know costs can be prohibitive to certain families, certain patients. However, there is free testing going on shortly.
Do we understand why the risk might be higher for African Americans or Southeast Asians?
They have the gene more often than other ethnicities. That's what we do know.
And does it get worse if you carry the gene your whole life? Does it get worse for you at certain decades or as you age?
We do see that the levels tend to go up slightly as we age. Once you're over the age of 50 or 60, you tend to see a slightly higher level.
So talk to us about the numbers that you might see on a report. I know they have those like little greater than, less than, if you're in the normal range or whatever that means, but help us understand what high means.
Yeah, so there are two different units of measure on these labs, and depending on which lab you run, high can be different. But generally, when you get tested for that particular lab, at the bottom, they'll tell you what a normal range is for their lab.
So it depends on whether you go to Quest or someplace else. Should you ask for a certain name of a test? Like, what do you ask for?
No, you can just ask for Lp(a). Ask your provider, your healthcare provider, to order an Lp(a), and they can test you for it, and it'll tell you where you're at. Are you high? Do you produce some? Do you produce none? And testing is the most important thing. Knowing whether you have the ability to produce it or you don't. And then amongst those who have the ability to produce it, how much?
Is it going to be a clear-cut answer, like it's above a certain number, or are you going to be in some kind of milky range that you don't really know?
And so there are cutoffs, and you know, depending on the lab and the units, it's hard to describe. But there are cutoffs. There are hard cutoffs.
So as you're talking to your physician friends, who obviously can speak about this I'm on a layman's level, but I'm on your expert level. What's the discussion among them? And without diving too much into the science, but what is the topic of the moment with Lp(a)?
So the idea is to try to break the cycle. You know, we see heart disease in generation after generation. Amongst my own patient panel, I have families. You know, I test one patient, they end up positive, and they send the rest of their family in to get tested. But the idea is to catch a risk factor early and to help the family mitigate risk. We do things by helping them address their lifestyle, you know, helping them quit smoking if they smoke, helping them reduce their alcohol intake, increasing their exercise. But we take steps to help mitigate overall risk with these patients.
And so, Bonnie, I know you can't give patients' names, and that's a given, but tell us some examples of things that you've seen happen with the patients that go through your cardio. You're at Baptist Cardiology on University Boulevard.
I'm in the university office.
There you go. Right.
I've had some patients that come in, and I had one guy kind of recently, actually. He had bypass and thought he was doing fine. Had some trouble with some statins, thought, they give me muscle aches, and had tried to kind of reduce it himself with diet and exercise. And then he came back in about 2 years later, a year and a half later, and had pretty bad chest pain, had an abnormal stress test, and he ended up closing off his grafts and went for redo bypass. He came in to see me for lipid management and said, I've never heard of this before. What can I do now? I checked his Lp(a) and it was through the roof. It was over 600. Our range is kind of, with the average panel, it's about 50, maybe 75 to over 600. And after 600, they give you a greater than sign, 600. So there are I'm sure some people are in the 800s, maybe in the thousands, and we don't know exactly how high they go. But it's true. They come in and they've not done well post-op and need more stents and need more work, and their numbers are real high.
And so how did you solve that situation?
For right now, I've got him on the most aggressive therapy I can have him on. We've lowered his LDL down into the single digits. He's on a statin, he's on Zetia, and he's on a PCSK9 inhibitor. So he's on 3 lipid-lowering medications. He has gone vegan himself and reduced his sugar intake, cut out alcohol. He has never been a smoker, but he's really reduced his inflammatory markers with diet, exercise, and lifestyle changes.
Well, that's encouraging. Mm-hmm. Okay, without a name, give me an encouraging story that you've seen in your practice.
Yeah, so I first had a 44-year-old patient who came in relatively healthy, told me a story about her mom at the age of 39 having a heart attack, and that's when I started checking her for heart disease. These days there are ways to screen for heart disease, and once I've discovered heart disease, that's when you start asking the question why, and especially in someone who's as young as she is, and knowing that her mom had disease and she has disease and she's in her 40s, that's when I started looking into Lp(a). Once that was discovered, I started checking the rest of her family. And it's very possible to help these patients avoid, major events. And that's just by understanding all of their risk factors and helping reduce every single one individually. It's the attention to detail that really helps these patients.
And so what turned out in that case with the LP little a?
Yeah, so her LP little a was elevated. I had a suspicion. These patients generally are, generation to generation have premature heart disease. So with her, I ended up treating her with a drug called a PCSK9 inhibitor. These are shots that you can get twice a month. And that has a 20 to 30% reduction. But it reduces your LDL, which is a separate risk factor, to a really low level. And just by doing that, you can really reduce their risk.
I just realized that we might be driving you crazy if you're listening, because you're going, I know, I kind of get it now what the LP little a thing is, but why is it little a? What's the little a thing? What does that mean? You guys explain that.
It's just the name. It's lipoprotein is the first part of the word. LP is lipoprotein. And then the A is in parentheses. It's kind of like on the screen, LP little a. It's actually a lowercase a, but it's in parentheses. So they call it little a because it's a lowercase a.
Yes, we should have had a little a right there on that. So now you mentioned statins. So let me just tell you just briefly. I remember years and years ago, I was driving down the road and my cardiologist called me because he had said, you're going to go on a statin if you can't lower your LDL or your LDL. He knew I'm an exercise freak. I do a ton of cardio. Usually my blood pressure is like 118/70, which I guess is good. I'm pretty healthy eating. I don't do fried stuff. I eat a ton of lettuce and all this kind of stuff. But anyway, he called me. He goes, I want you to pull over and listen to me. So I pulled into a parking lot. He said, I don't care what you do. You have not lowered your cholesterol, and it's not your fault. And so he put me on Crestor. So I have been on 5 milligrams of Crestor for years. But I might be like somebody else who's thinking, well, I'm on a statin. Wouldn't that help with the LP little a? And I'm gathering from you all, no, right?
No. So unfortunately, no amount of exercise, dietary changes will change that number. And drugs, there are some drugs that can help to a certain amount, but most drugs will not reduce it. But you can reduce risk with other cholesterol, like your normal LDLs, and that's just as important.
So if you're on a statin, don't think that's going to solve this LP little a problem, right, Bonnie?
Correct. Yeah.
All right, so what do you want to advise people as far as when they should get to? They may think, well, I don't really need to worry about heart disease, because you mentioned a 39-year-old woman, right? And I want to point that out, because you shouldn't be thinking, if I'm correct, oh, I'll worry about that in my later years, not with this topic, right?
That's correct. So, a good portion of my patients are in their 40s and 50s. And most people do not know that they have heart disease. There are ways to screen it, and heart disease remains the number one killer just because you can't really feel a difference whether you have heart disease or not until it becomes more advanced. And so, right now there are screening tools. Ask your doctor about it. But we generally calculate a risk. Sometimes we can get more objective data by doing certain tests, like a coronary calcium score, and that can detect disease long before you ever have any events.
All right, so for everybody out there who wants to be smart, who wants to figure out what's going on with their health, this test takes just a couple minutes, really, and it's easy to do, and then you'll have more information in your guidebook for your life and for your whole family. Like you say, we see whole families, right, Bonnie? Coming
families.
in. Like mom, dad, grandma. I was at the house the other day of 3 generations. They're all going to get tested, right? Does that make sense?
Mm-hmm.
Okay,
Absolutely.
so one more little pitch from you guys to make sure everybody stays healthy. What would you like to say as we kind of wrap this up? Dr. Mai?
Yeah, so we offer a lot of preventive services at Baptist, and if you have any concerns with your cardiovascular health, come see us. We'll check you out.
All right, good job. Bonnie?
We would love to take care of you. Heart disease is the number one killer of humans, and we see it a lot. Come in. If you have family history, if you've got a concern about heart disease, if you have chest pain, come see us. We'll take care of you. We'll do a good job and rule out all that bad heart disease.
Rule out all the bad stuff. So, and if your dad were sitting here right now, Dr. Smith, what would he say? What would be his final word to everybody?
Know your risk. Know your risk. It's best to know your risk and mitigate your symptoms.
I do have to go back to that story you told us. We maybe look at a picture of her with her dad one more time, because as you guys were talking, he's like, Oh, it was not that big of an event. It was a little event, and you kind of went ballistic on that, right?
Yeah, he said, "Oh, it was just I had a little teeny heart attack." And it's true. His troponin was really pretty low still, but he had 5 blockages. 5 blockages is a lot, and that's a big heart attack when you're the daughter, when you're the kid of this young cardiologist that's going through this. He's 55, so yeah, it's a big deal. So I'm glad that we still have him and that we've been able to fix this for
I
him.
think you love your dad a lot,
I
right?
do. I love my dad so much.
He sings to the grandchildren and everything.
Oh,
and if we could
it's
just
the
be on,
best.
I want to end on a personal note because that's what this is all about, is staying alive for the people who love you. I'm in pink because it's Buddy Check Day. And
Yes.
that's breast cancer catching that early, how important. So we're big proponents around here of trying to make sure that you stay alive for people who need you. And so, Dr. Mai, I know you've just gotten married, so I know you've had your LP(a) tested.
I have not.
Oh
but I will.
no! Oh no! Your your newlywed wife over here is having a fit. Why have you not gotten tested?
So that's a great question, right?
You will now, I bet you.
Yeah.
I didn't mean to put you on the spot. I just figured your answer would be yes. So, but that's
If you
okay.
need someone to manage it, let me know.
Yeah.
So this is all very human, just down to the grassroots level. So thank you all for listening. And if you have any questions, feel free to reach out to these nice folks from Baptist with their high level of expertise and their passion for just human beings. So LP(a) testing, you see right there. It's free March 17th through 19th. That's on 5310 Lenox Avenue, 7:30 a.m. to 4:30 p.m. You can just walk in, but I've been talking to the organizers. They would prefer that you do make an appointment just to save you time at visit myfreehearttest.com. That's not the only possibility. There are other programs as well, and you can contact Baptist if you want to get tested. So thank you for listening. I hope you learned something, and I'm going to go get tested too, Dr. Mai, I promise. Good night.
I'll join
everybody.
you.